Hi, this lecture is about calcaneus fracture, both acute calcaneus fracture and calcaneus fracture malunion. A good source that you can use is this book written by myself. So there's two important angles that play important part in decision making and the severity of the calcaneus fractures, the Bowler angle and angle of Gissane. The Bowler angle, which is the important one of these two, is the angle between two lines. A line here from the highest point of the tuberosity to the highest point of the posterior facet, and another line from the anterior process here, highest point to the highest point of the posterior facet. So this angle here should be around 20 to 40. If the patient does not have a contralateral calcaneus fracture, you can always take the other side, and that will be the normal of this patient. Usually, as we said, between 20 and 40. So it's between two lines, one line here from the highest point of the tuberosity to the highest point of the posterior facet, and from the anterior tuberosity to the posterior facet. The angle here is 20 to 40. With calcaneus fracture intra-articular, this angle becomes much less, and in many times it becomes inverted. The angle of Gissane here between the anterior middle facet here and the posterior facet, this is where the talus with the axial load will go inside and cause the fracture, start of the fracture. So this is called the angle of Gissane, and this is what receives here the lateral process of the talus. This angle is about 120 to 140. So the numbers 20 and 40 are the normal in both. So a Bowler angle 20 to 40, Gissane angle is 120 to 140. So calcaneus fracture can be classified as extra-articular and intra-articular. The word articular refers to the subtalar joint. So extra-articular means it's away from the subtalar joint. Intra-articular means involves the subtalar joint. So let's start with the extra-articular fracture. Extra-articular fracture include the anterior process fracture, which sometimes like a small avulsion fracture or involves the calcaneocuboid. We're going to show some examples. The other important one, very important extra-articular, is the tuberosity fracture and tuberosity avulsion, and these are extremely important because they are considered emergency, as we're going to discuss later. And the third one, which is also important, is the sustentacular fracture. So all these fall into extra-articular fractures, and we're going to go through them now. So let's start with the sustentacular fracture. As you see, the sustentacular is the medial side. This fracture is not common. Actually, most of the fractures of the calcaneus are the one which is intra-articular in the subtalar joint here. These ones are rare, about 1% only of the calcaneus fracture, and it involves the sustentacular tali, the medial side of the calcaneus. They are called sustentacular fracture. So the calcaneus, the tuberosity is intact, the fracture happened in the medial part. So this is one of my patients here with sustentacular fracture. You can see the CAT scan showing the displacement of the sustentacular fracture. So patient was taken to surgery, incision over the medial side, and then compression to reduce the fracture. And then the fracture after that is fixed with compression screws, either compression by design or compression by technique. Sustentacular fracture, as we said, they're rare, only about 1% of the calcaneus fracture. They're considered extra-articular, and if displaced, they should be fixed from a medial approach. Very important extra-articular fracture is tuberosity avulsion. Calcaneal tuberosity is this part of the calcaneus. It has the attachment of the Achilles tendon, and when there is a tuberosity avulsion that is displaced, this is a true surgical emergency. Why? Because this piece here will start pressing on the skin. The skin in this area is very tenuous, and with the displaced calcaneal tuberosity, it has the attachment of the Achilles tendon. It starts pushing on the skin here, and the skin can get pressure necrosis in only few hours. This fracture commonly happens in diabetic, which makes the condition worse. So tuberosity avulsion fracture, when they are displaced, this is a true surgical emergency because it causes pressure necrosis on the skin of the posterior heel. You need to take this patient as soon as possible and reduce the fracture. This is a very clear example. Here is the calcaneus. This part is the calcaneal tuberosity. It has the attachment here of the Achilles tendon. So the Achilles tendon is attached to this part here of the tuberosity. It pulled it proximally with the pull, and you can see here how the skin is being pressed by the piece of bone. So if you see this area here, the Achilles tendon is attached here. It pulled this piece, marked displacement, pulled proximally. This piece of bone is pushing on the skin. This skin is getting pressure necrosis. This is a true emergency. This patient needs to go immediately to the OR for reduction and fixation. So tuberosity fracture commonly occurs in diabetic patient. This is the patient that we had the X-ray in the previous slide, and you can see she presented to the ER fairly late, about 12 hours, and you can see when she presented, the skin already had necrosis there due to the pressure by the piece of bone. So this is the patient in the previous slide. The patient was taken the next day, so she was not taken on urgent base, where open reduction and internal fixation was done. You can see the tuberosity was put back in position, fixed with cannulated screw and the washer. However, because the delayed in presentation and delaying of the patient taking to the OR, patient presented with skin sloughing and major complication. As you can see here, both in this area and in this area, there is major skin sloughing. That's why tuberosity fracture is considered an emergency. You need to take the patient as soon as possible, and it's better to do them through minimal invasive approaches without extensive skin incision and dissection to avoid these complications. Another example, here's another example that you can see, same thing, tuberosity avulsion. Achilles tendon is attached to this part here, so you can obviously see the skin color here started to change. So this is a diabetic patient. This patient presented immediately after the fracture. She actually had a fracture of the ankle together with the calcaneus fracture, but the patient was brought emergently for the calcaneal tuberosity fracture because this is the thing that needs to be done immediately. And if you can see here, she was done percutaneously, so through a small incision less than 2 centimeter, like incision of about 1.5 centimeter was done, and then a reduction clamp was applied percutaneously, and the reduction was obtained, and then fixed with 2 screws. You can see here, this is the condition of the skin after about 3 weeks after suture removal. You can see completely healed, very tiny incision, and you can see here the reduction with 2 screws through a percutaneous approach. So now, after we talk about extra-articular calcaneal fracture, we'll shift to the very important topic, which is the intra-articular calcaneal fracture. Intra-articular calcaneal fracture has a very specific pattern in the calcaneus. So these fractures, there is a primary fracture line and secondary fracture line. So the primary fracture line, as you can see it here and you can see it here, it goes from anterolateral to posteromedial. It goes from anterolateral to posteromedial, and in the anterolateral it's proximal. As you can see here, in the posteromedial it's distal. So it goes from anterolateral to posteromedial. This is the primary fracture line, and it is due to the axial load. So the axial load causes the talus to abut against the calcaneus and causes this primary fracture line. This will result in 2 main segments. There is this segment here, which is usually referred to as the sustentacular segment, and this is the medial side, and there is the lateral part, which is usually referred to as the tuberosity segment. So we have the sustentacular segment, which is the medial one, and the lateral one is the tuberosity. So anteromedial part here called sustentacular part or medial part, posterolateral part here usually called tuberosity part. So this is the primary fracture line here, and this is the displacement that happens with this fracture line. The posterolateral part will go proximal, the anteromedial will go distal. And then there will be secondary fracture line, as we're going to see in the next slides. So we talked about the primary fracture line, as we said, anterolateral to posteromedial. And this is, as we said, it's related to the axial load. So the talus goes into the angle of keying, causing the main fracture line, separating to a medial side, which is usually called sustentacular side, and the posterior lateral side, which is called the tuberosity. And then we get the secondary fracture line, which can be anywhere. If the secondary fracture line goes all the way, so it has part of the tuberosity here, this one we call tongue depression. So if you get the secondary fracture line and this fracture line goes to the tuberosity, posterior part of the tuberosity, this is called tongue depression type. If you get the secondary fracture line to go anterior to the tuberosity, this is called joint depression. So the two main types of the intra-articular joint depression, when the secondary fracture line does not extend to the tuberosity part. When it goes all the way here to the tuberosity part, it's called tongue depression type. So intra-articular calcaneus fracture is a well-known fracture of associated soft tissue injury that can sometimes be massive, as you can see here. So this is intra-articular calcaneus fracture that is associated with an obvious fracture blister and soft tissue swelling. And it is important, if you decided to proceed with calcaneus fracture fixation, especially with extensile lateral approach, that, as we're going to see later, you have to wait till the soft tissue condition gets better. This is another example of the soft tissue complications of calcaneal fracture. So you can see this is a young patient, about 6-year-old female, one of my patients, with what seems to be very minimal calcaneus fracture. So the fracture line here, you can see it's very minimal. However, despite this like basically non-displaced calcaneal fracture, you can see the amount of hematogenous bully that developed with this patient. Calcaneus, most of the part of the calcaneus are subcutaneous, so this bone can have massive soft tissue injury. So even with very minimal fracture, even in small children, you can see the amount of fracture bully and swelling that happens. Another example here of soft tissue injury, you can see the marked swelling, and you can basically see there is no creases into the foot. So this is an indication that this foot is swollen. It is not recommended to do extensile lateral approach in these cases, as it can cause to massive skin problems, and you have to wait till the soft tissue gets better. So let's describe the pathology in the intra-articular calcaneus fracture. As we said, the mechanism of injury is axial load. The talus will go into the angle of Gissane and causes the fracture and the deformity. You can see here, so it's an intra-articular fracture. So this type here is the joint depression because this part here is not connected to that part. So the posterior facet now is separate from the tuberosity. So this is joint depression. You can see here that this is the joint here is depressed. This part here should be parallel to the talus. It is like 90 degrees. So this part here, after reduction, should be parallel to the talus here, about only like 30-degree inclination. You can see that the height of the calcaneus is less, so there is loss of height, and when there is loss of height, the calcaneus becomes wider, so the foot become wider and the heel is wider, so you have wider heel and loss of height and shorter. Also you get articular incongruity because here the talus is not congruent with the subtalar. You can get varus or valgus. However, in the vast majority of cases, calcaneus fracture is associated with varus. I'm going to show example for that. All these are considered as the deformity that happen with intra-articular calcaneus fracture. So we're still continuing with that same patient. This is one of my patients. This is the same patient as we saw the CT in the previous slide. So you can see here obvious varus. As we said, most cases of calcaneus fracture will have varus. You can see here that the tuberosity is pointing medial. This is the medial side, as you can see here in the arch, and this is pointing medial. And also you can see here, this is, as we said, this is the medial side. This is, or the sustentacular side, which and sometimes they are called the constant side because they don't move that much, because if you can see here, it kept its relation with the talus. And here is that we said is the broadening, the widening that happened in the heel, and the shortening. So all this again is the deformities that we can see typical of intra-articular calcaneus fracture, the joint depression, varus, shortening, broadening. The medial side is the sustentacular side, which we usually call the constant side because it keeps its relation with the talus, while the tuberosity side is the side that moves. So we're going to speak about X-ray assessment of these patients. We spoke about in the first part of the lecture about the Bowler angle, which is from the anterior process of the upper part of the anterior process of the calcaneus to the posterior part of the posterior facade. This is one line, and the other line is basically to the posterior tuberosity, and this angle should be 20 to 40 degrees. If you see here, this is basically zero angle. The three dots are on the same line. So this is an indication that there is depression of the calcaneus. There is a depression here in the joint, so it's not as it used to be. If you can see here, this part here should be parallel to the posterior facet of the talus. So this is indication of loss of the calcaneal height. Also, you can see in the X-rays the other lines of the fracture here. You can see that the fracture here also extends to the plantar surface, and there is some plantar displacement of the fracture. All this you should assess in the X-ray. You see the posterior facet of the calcaneus here is not parallel to the posterior facet of the talus, and it is not one piece connected to the posterior tuberosity. So this is not tongue type, this is joint depression type. As you see, there is loss of the height, which can be indicated by flat Bowler angle. So for radiological assessment of calcaneus fracture, of course, you will get a lateral view and axial view of the calcaneus. Also, very specific view for the calcaneus fracture is the broadened view, and actually this view is important intraoperatively. So by the C-arm, you should try to get the broadened view to assist the reduction of the subtalar joint. How do you obtain the broadened view? Is basically with internal rotation of the leg, about 20 to 30 degree internal rotation, and then you focus the beam 10 to 40 degree cephalad, as you can see here. So internal rotation, and then you get the beam from 40 to 10 degrees, and you take several shots with your C-arm. So you bring the C-arm this way, and then you decrease the angle till you get the 10 degree. And if you notice, when you get 10 degree, you are basically looking for the posterior part of the posterior subtalar. When the angle is 40 degree, you're looking to the anterior part of the posterior subtalar. So again, broadened view, very specific view for calcaneus fracture, especially intraoperative. So when you're doing this surgery, you need to get the broadened view. Is very easy to obtain. Internal rotation of the leg, internal rotation of the foot, about 20 to 30 degree, and then you get your C-arm in 4 different degrees between 40 and 10, aiming cephalad this way. Every time you will assess part of the subtalar, all of them is the posterior subtalar. When it's 10 degrees, you're basically looking for the posterior subtalar. When it's 40 degree, you're looking for the anterior part of the posterior subtalar. CAT scan is a very important imaging modality for calcaneus fracture. Basically, all cases that you plan to fracture, or you're considering, or you plan fixation, or you're considering fixation, should get a CAT scan. And it's better to take the cuts parallel to along the axis of the calcaneus. So you can get better information. You will basically assess the three pictures: the axial pictures, the coronal, and the sagittal. The sagittal helps you to see the depression of the posterior subtalar. So if you see here, this part here should be actually parallel to the talus. In the coronal, you can see the amount of varus or valgus. As we said, most of them will have varus. And it will show you also the bone comminution, number of the fracture line, and if there is a area that is void. Same thing in the axial, will show you the constant fragment of the calcaneus. It will show you the number of the fracture in the subtalar, and will help you with the Sanders classification, as we're going to see later. So about the classifications of calcaneus fracture, there is two main classifications that are frequently used: the Essex-Lopresti and the Sanders classification. The Essex-Lopresti is the very historical and classic classification of the calcaneus fracture, and we had mentioned that before in the early slides. So we said that the primary, it depends on that there is a primary fracture line that will go from anterolateral to posteromedial, and then there is a secondary fracture line that can go anywhere. So this is the primary fracture line, as you can see here and here, and then the secondary fracture line. If the secondary fracture line went to the posterior tuberosity, maintaining part of the tuberosity with the posterior facet, this is called tongue type. So this is the tongue type Essex-Lopresti. So it's basically the joint here is connected to part of the posterior tuberosity. And why is that important? Because basically if you reduce here to here, you reduce the joint. So this is tongue type. The most common type, the more common type is the depression type. So in that part, the secondary fracture line will go here anterior to the posterior tuberosity. So if the secondary fracture line goes anterior to the posterior tuberosity, this is called depression type, joint depression type. If it goes all the way posterior, including part of the calcaneal tuberosity, that's called tongue type. This is much less common. This is much more common. There will be other fracture line that goes here, depressing the joint. So that most of our talk will be on depression type. So this is an indication here of a tongue type. So the fracture line goes from the articular surface all the way to the posterior calcaneus, distal to the calcaneal tuberosity. So if this fracture here is fixed, that's an indication that the articular surface is reduced, because this all is one segment. So if you reduce the plantar and dorsal calcaneus together, the articular surface should be reduced. One thing I want to emphasize here: this is not tibial tubercle, this is not calcaneal tuberosity avulsion. So this is not an avulsion of the calcaneal tuberosity, as we saw in the beginning of the lecture. In this case, if this was a calcaneal tuberosity, you have to have a fracture that goes here anterior to the calcaneal tuberosity, but you see the fracture goes all the way to the articular surface. So this is a tongue type. So this is tongue type calcaneal fracture through the Essex-Lopresti classification. So if you reduce this to this, that's an indication that the articular surface is reduced. This is not calcaneal tuberosity avulsion. This is a tongue type fracture, and here it was fixed with 2 screws. Same thing here, another example, the X-ray, you can see the fracture line, the CAT scan here. All this is one fracture here. So if you reduce this piece to this piece, that's an indication that the articular surface is reduced. This is not a calcaneal tuberosity avulsion. If it's avulsion, we will have a fracture line that goes here. This is a fracture that goes all the way from the articular surface to the posterior calcaneus. It's not a calcaneal tuberosity avulsion. However, also this was treated percutaneously with reduction clamp, and then 2 screws were applied. And if you fix the dorsal posterior to the anterior plantar calcaneus, the articular surface will be reduced because all this is one type. So this is a tongue depression type of the calcaneus fracture. So the more common classification is the Sanders classification. The Sanders classification is basically describing the number of the displaced fragments. So, and it's based mainly on the CT, especially the coronal CT. So the coronal CT will gives you how many displaced parts. So if you see Sanders 1 is basically non-displaced fracture, even if there are fracture lines, you will still, if they are non-displaced, this will be considered type 1. Type 2, when you have one fracture that goes into the subtalar joint and it's causing displacement more than 2 types. Type 3 will have two fracture line that is giving you 3 pieces, and type 4 it will be 3 fracture line or more with high comminution and displacement. There is subtypes, basically that's mainly in type 2 and type 3 in which you describe A, B, and C, and it depends on how medial is the fracture line, or the most medial fracture line, how medial it is. The more medial you go, the higher will go, so it will be in either B or C. Why? Because your fixation is mainly going to be into that medial sustentacular piece. So if the fracture is more medial, that will make your fixation in a smaller piece, and that's why it goes into C. As we said, fracture type 1 is non-displaced fracture. Type 2, one fracture line with 2 pieces that are displaced more than 2 lines. Type 3, 2 fracture with 3 displaced fragment more than 2 millimeter. Type 4, 3 fractures or more with high comminution and displacement. Especially type 2 and type 3 are classified A, B, or C based on the fracture line. The more lateral it is, the fracture will consider be A. The more, if it goes medial, it becomes B or C based on how medial it is. Basically, the idea is when the fracture is medial, more medial, your fixation will be harder because the constant fragment, as we're going to talk, is smaller. So this is Sanders classification. It's commonly used. It depends on the displaced fragment and the number of the fracture lines. So now let's speak about treatment of calcaneus fracture. We spoke about the pathology. Now let's go for the treatment. The treatment, as any other fracture, it's either operative versus non-operative. And this should be a very detailed discussion between you and the patient. And you have to discuss basically what are the advantage and disadvantage of each line of treatment. So we know that operative treatment gives the best result in young patients, less than 40 years old, non-smoker, very important, and non-diabetic patient, unilateral injuries. So patients who have bilateral injuries, they don't get as good result. Female get better result than male. This is very important. Non-labor jobs. So when you go, especially patients who work in construction, you have to tell them that we can do operative treatment, but the result may not be as good because you'll be working on concrete and unlevel ground. Also, if the case is non-workers comp, because worker compensation patient usually does not do as good. So worker compensation means that if this condition happened during work, and basically the work is compensating for that. So treatment, it's operative versus non-operative. You really need to discuss the advantage, disadvantage, the complication with the patient, so that you can take so the patient can take a decision. One of the things is to tell him, when do you expect to have a good result? It's in young patients, female, non-workers comp, non-smoker, unilateral, non-labor, and non-workers comp. Poor outcome on the other side, it's obese patient, diabetic patient, very important. In diabetic patient, I usually try to stay away from surgery. In my practice, I very rarely do calcaneus fracture on diabetic patient. Obese patient, they get poor result. Smoker, I try to stay away from any surgery on smoker patient unless I'm going to do something percutaneous. Male patient don't get as good results, and worker compensation patient. So this is one of my patients here. You see how much depression here, and then basically the treatment is to reduce this, as we're going to talk about later. We put the fracture back in position, and you can see the subtalar joint is restored with application of the plate, and we're going to discuss the treatment details later on. So why do we go for operative treatment? As I saw you in the previous slide, you have the subluxation and displacement of the posterior facet, and you have loss of height, as we're going to talk about in the malunited calcaneus fracture. So you get loss of height, you get wide calcaneus, you get in most cases varus, and of course you get displacement of the posterior facet. So you will get subtalar arthritis and decreased range of motion of the subtalar joint. So basically the main line of treatment is to get back the subtalar joint, get that joint back into position as we saw in the previous x-ray, so the patient can avoid the subtalar arthritis and have better range of motion. So why we don't do surgery basically for every patient if we're going to get the subtalar reduced? Because of basically we're worried about the complication, which is mainly skin dehiscence. So in calcaneus fracture, the most dreadful complication that you try to avoid is a skin dehiscence, which will result in a secondary infection. So in the cases of calcaneus, especially if you do them through the extensile lateral approach, you're worried about the skin, which will lead to secondary infection. In the very early studies, this was high. However, with better techniques now, both in the sinus tarsi approach and in the extensile lateral approach, the incidence is much lower. But again, the most dreadful complication is skin dehiscence. And as we said, why do we try to do treatment? Why we don't just treat all of them non-operative? Because basically if you treat them non-operative, they're going to get malunion, and we're going to speak about malunion in details at the end. But basically the most important thing is you will get subtalar arthritis, because you, as we said here, this facet is down, so it is pushed down here. You lost height, you lost the mechanics, and we're going to speak about that in details. And then patient will have subtalar arthritis, decreased range of motion, and will have pain during gait. So that's why we try to avoid non-operative treatment in displaced fracture, because we want to get them back reduced to a normal position, and then after that get both better mechanics. So this is basically the advantage and disadvantage of operative and non-operative treatment. So if you decided to do operative treatment, the way to decrease the skin complication is basically delayed open reduction. So we go for delayed open reduction and internal fixation. So we don't try to do acute internal fixation in cases that you're going to use the extensile lateral approach. If you are doing a sinus tarsi approach, you can definitely go early. I go early with my sinus tarsi, unless it's like extremely swollen. But I would say in most cases, if I'm going to do sinus tarsi, I go early. I don't wait too much. But if you're planning to do extensile lateral approach, as we're going to show, you have to do delayed surgery in most cases. And what are you looking for? You're looking for the wrinkles sign. So what is the wrinkle signs? Basically, the wrinkle sign is when you evert and dorsiflex the foot. If the patient is still swollen, you won't see any wrinkles. If it's the swelling has went down, you can see the wrinkles, as you can see here in the difference between these two. So here, after 2 weeks, the swelling went down and you can see the wrinkles. So that's what are you looking for, wrinkle sign, which basically indicate less swelling, and that the patient is now ready to proceed with surgery. So as we said, there's two main incisions that we can use, two main approach, the sinus tarsi and the extensile lateral approach. So this is one of my patients here. I prefer to use the sinus tarsi in most of my cases. And the sinus tarsi, we're going to talk about it in details in the next slide. But basically, it takes you directly to here to the posterior subtalar, and you can reduce the posterior subtalar and apply a plate or screws, or just the screws, with, depending on the surgeon preference. Or you can do the classic extensile lateral approach, and we're going to talk about that also in detail. So the sinus tarsi approach, basically you go from the tip of the fibula to the base of the fourth metatarsal in this line, straight line. It does not have to be a small incision. You can go all the way from here to here. The idea of the sinus tarsi, it's not like it's a small incision. The idea is that you don't raise a flap. That's very important, and that's what you need to keep in mind. So the sinus tarsi, it's not minimally invasive approach. It is less invasive than the extensile, but it's not minimally invasive. You're basically going to open and see everything. The main difference is you're not going to raise a flap. So you open from the tip of the fibula. You can also go slightly posterior and release some of the fibulocalcaneal ligament to the base of the fourth, and then you find the peroneal tendon. You release them and pull them laterally, pull them plantarly. I'm sorry. and then you will clean the subtalar joint, remove the interosseous ligament, and you will be able to see basically your talus, and this talus will act as the mold that you're going to reduce the joint for. As we saw, we showed this picture before. This is one of my patients. You can see we did he's like skeletally immature. You can see the physis here and here. So what this here, the subosseous facet has to go all the way to here. So this point here needs to be here, and that will basically push everything up and reduce the deformity. This is basically what you're going to do with this approach. You will reach to the subtalar joint, and once you reach to the subtalar joint, you reduce it, put screws or put plate, whatever you prefer, and after that you can have better subtalar joint, better range of motion, and also when you pull this piece back up, you basically also restore the height. So another example of calcaneus fractures to help you go through the sinus tarsi approach. So this is a patient, of course you see loss of calcaneal height, highly comminuted fracture. Volar angle is basically very flat. The fracture goes all the way down here with extension of the fracture to the plantar surface. So this is a highly comminuted fracture, as you can see. In this fracture, CAT scan is very important. It shows you, as you can see here, the amount of comminution anteriorly, if there is extension to the calcaneocuboid joint, and also, of course, it tells you if there is depression of the posterior facet, which you can control that through the sinus tarsi approach. And again, it shows also you the fracture posteriorly. That fracture will need fixation by screws. The CAT scan here, the axial cuts will show you the Sanders classification. So there is two lines here. However, basically this one is the main line that has the displacement. This one is basically non-displaced. So there is two main fragments. The same thing, you can see it here. One is displaced and the other one is just non-displaced fracture. Same thing, you can see it here in this CAT scan. So through the sinus tarsi, you see reduction of the posterior facet, restoration of the volar angle, you can see it here, and restoration of the posterior facet, and that allow to help avoid the subtalar arthritis. And then, as we saw before in the CAT scan, there was an anterior fracture. This was fixed by a screw. The subtalar joint after reduction was fixed by a screw, and then the fracture that was posteriorly fixed with two fractures here. One of them is pointing towards the subtalar to support it from later depression. Through the sinus tarsi, the fracture was fixed. 3 months follow-up, you shows here is maintenance of the volar angle, the screws anteriorly, the screw through the posterior facet to keep the posterior subtalar joint. The fractures here in the posterior part completely healed. This is the axial here. The correction of the deformity was obtained. There is no varus or valgus. Good alignment. And despite we said in the beginning that the construction worker and the labor patient do not do good, this patient 1.5 years after the surgery, I saw him for a follow-up visit. He was pain-free and he returned back to construction. You can see the alignment. There is no varus or valgus. Patient standing with excellent alignment of his hind foot. Now, after we talked about the sinus tarsi, let's go to the more classic approach, extended lateral approach of the calcaneus. In my practice, I don't do this approach oftenly. I prefer the sinus tarsi. However, a considerable amount of trauma surgeon and foot and ankle surgeon will use this approach in most of their cases. And as I said, this is more classic, extended lateral approach. And as we said, if you decided to go for the extended lateral approach, you need to wait for the wrinkle sign. So wrinkles is a good sign. It indication that the swelling has went down, as we discussed before.
And after that, you do your incision. I have these pictures from the AO website. It's a very good website, and I recommend it for people who would like to read about their surgeries. When we do the extended lateral approach, however, this line here is not really in the correct. You need to go, the vertical line is just anterior to the Achilles tendon. It's not midway between the fibula and the Achilles, so you go just anterior to the Achilles tendon, and you go all the way to the junction of the lateral skin with the plantar skin. We call it the glabrous skin, so the plantar skin, sometimes called the glabrous skin, and the lateral dorsal skin. So the incision here is usually at that lower, slightly lower, and here is a slightly more posterior. So this should be like the incision here is slightly more posterior, and the incision here is slightly more plantar, just anterior to the Achilles and at the junction of the glabrous skin with the lateral skin. This will help you to avoid the sural nerve. And then the most important part of the incision is this corner here. This, you have to treat this very gently to avoid any problem, because when problems happen, it starts at this area. So you will go deep tissues, and then there is no subcutaneous dissection. You just go here all the way to the calcaneus, and then you raise flap of the calcaneus. So the flap here, which is going to be raised all the way, it's raised all the way at the level of the calcaneus. You don't go subcutaneous in this approach to have a good flap, and this area here should be handled very gently. So as we see here, it's dissection is subperiosteal all the way. So you go all the way here, and you raise everything subperiosteal. And with your subperiosteal, you will take the peroneal tendon till you can see the talus. Once you can see the talus, you basically apply 2 wires, and this is called no hand technique. So these wires, you bend them and become the retractor for the skin, and you can always change the rotation a little bit so they are not on the same exact area, and that will allow you to have no hand, basically meaning that no one touches this flap. And again, it's a subperiosteal flap. Most people will tell you that the limbs here will be slightly more plantar. This will help avoid the sural nerve. And then once you close, we use usually the Abdelgawad the sutures, basically meaning that you put the knot here in the posterior and the plantar part, not on the flap. And on this side, it's subcutaneous. So it's the skin on this area, subcutaneous on the flap. So you don't have any knot here. So you try to avoid any pressure on the flap to avoid any skin necrosis. This will allow you basically to see the whole calcaneus. You can reduce the subtalar. You can reduce the lateral wall blowout. As you can see here, there is a lateral wall blowout. You can manage the lateral wall blowout much better than the sinus tarsi. And if you use this approach, basically everyone will put a plate. Most of the sites now has calcaneus specific plates that you can use. One important point for the fixation of the calcaneus fracture is you always build on the medial side, as we discussed before on the Sanders classification. We said that one point of the Sanders classification is how close you are from the medial side. Why? Because the medial side is usually the stable part, or we call it the constant part, and you build your fixation to this area here. So as you can see here, if you have one screw that is long and below the sustentaculum tali in this area, this will irritate the flexor hallucis longus. This sometimes comes in the exam, so they will show you a screw that is long and tell you what will result in. It will result in irritation of the flexor hallucis longus. So always build on the medial side, which is the constant part. When you put your screws, you're planning to capture this sustentacular area or the stable area. If you go underneath and long, what structure you're going to irritate is the flexor hallucis longus. So this is some CT cuts and X-rays of one of my patients. As I showed you before, on the lateral cuts, when you see a sagittal cut that has this basically like 90-degree alignment of the posterior facet, this needs to be reduced, and this point here needs to be here. Also, you can see the amount of bone loss. There's no bone loss. It's actually like just collapse of the bone, because this is all cancellous bone. In this case, there is too much bone that was compressed, as happens in tibial plateau. And you can see here the medial cuts show the amount of shortening, and you can see the varus in these cuts. So going through the CAT scan and the X-rays will help you. And of course, you can see here loss of the polar angle. It's basically became 4 degree or a straight line. So you can see the major depression that happened, the amount of bone loss, the amount of collapse of the bone that happened, the amount of varus shortening. All this you can judge from the X-ray. And in this case, patient here, we did a sinus tarsi approach. So I went medially to put the external fixator to correct the severe varus and shortening that this patient had. We applied this device called a femoral distractor. You can basically apply any external fixator, and we distracted the joint. If you can see here, we were able to restore the polar angle. We were able to restore the angle of Gissane by pushing this piece back to in position. This piece that was here, we pushed it back in position. Now the subtalar joint is reduced, and of course you have now a major area that we put a synthetic material. In this case, we put calcium phosphate to help in the collapse. And you put your fixation. And when you use your sinus tarsi, you can always use screws or pre-contour the specific plate, or you can just put screws. And also after you correct the varus and the shortening, you can apply other screws here to support the subtalar joint and to maintain the posterior fracture and fixate the posterior fracture. So what to do with open calcaneus fracture? It depends basically on the side of the affection. If it's on the medial side, and if it's type 1 or type 2, surgical reconstruction can be done. Remember, we always go on the lateral side, or like in the vast majority of cases. If the open fracture is on the lateral side, in this case, there is an increased risk of infection or complication. Most people in this case will do just debridement, and then once the wound is healed and the fracture is healed, osteotomy or fusion can be done. So open fracture depends on the which side is affected. If it's on the medial side and it's type 1 or 2, surgical reconstruction can be done. If it's on the lateral side, there is an increased incidence of infection and complication. So malunited calcaneus fracture, this is an important topic. Why? Because some fractures of the calcaneus will be treated non-operative because either they are very highly comminuted that you don't expect to get a acceptable reduction, or patients are not good candidate like smoker or diabetic or very elderly. So the result will be malunited calcaneus fracture. So what is the pathology in malunited calcaneus fracture? As we talked before, most important thing is subtalar arthritis, post-traumatic subtalar arthritis, as you can see here. So the posterior facet is displaced, so patient will develop posterior subtalar arthritis and limited range of motion, especially eversion or inversion. The next thing is varus. Most commonly patients have varus. Some of them will have valgus, but most common deformity after calcaneus fractures, malunion, is varus. And then there's one which is very important because it actually reflected on treatment of malunited calcaneus fracture, which is loss of calcaneal height. So as you can see here, this patient basically, beside the subtalar arthritis, lost the calcaneal height. You can know this from polar angle. Basically, the polar angle, as you can see, is 0. There is no angle at all. So what will this do? It basically will result in what we call flattening of the talus. So you should have like an angle this way in the calcaneus that will carry the talus into an inclined position. But with loss of calcaneal height, what will happen is you will have flat talus or horizontal talus. What will the horizontal talus do? It will cause anterior ankle impingement, limited ankle dorsiflexion, and pain in the anterior ankle. So loss of calcaneus height, as you can see here, this is one of my patients. He actually presented with anterior ankle pain after malunited calcaneus fracture. Why? Because loss of calcaneal height, the talus becomes horizontal, and when it becomes horizontal, there will be a limited ankle dorsiflexion and will be impingement here. So the talus should be like this. So the patient or regular person can do dorsiflexion without impingement. When the talus becomes horizontal, it becomes impinging here with limited dorsiflexion. Of course, other things, broadening of the calcaneus that will affect the shoe wear, and sometimes you get calcaneocuboid arthritis. Sometimes you, especially with malunited tuberosity, you can get Hagelin deformity, and you can get plantar exostosis if the fracture affects the plantar surface. So this is the treatment for cases of patients who have arthritis and the flat talus. Basically, the talus, as we said, should be oblique. When you lose the calcaneus height, the talus will be flat, impinges anteriorly, causes anterior ankle pain and limited dorsiflexion. So this is one of my patients, malunited calcaneus with arthritis. Loss of dorsiflexion, anterior pain. Basically, the first thing is to fuse the joint, so the cartilage is removed, but it's not the regular arthrodesis. This is a very specific type of arthrodesis called block distraction subtalar arthritis. Basically, what does it mean? It means that you, as you can see here, you are looking to recreate the normal anatomy of the calcaneus and talus. So you want to put a distraction here. So that's why it's called distraction block arthrodesis. So when you get a question in your exam, what is the treatment of a malunited calcaneus fracture with anterior ankle pain? The treatment is by subtalar arthrodesis, a very specific type called block distraction arthrodesis, basically meaning that you will put a block, a graft here, and you're going to use this graft to distract the subtalar joint. So it's called block distraction arthrodesis. As you can see here, we applied the wires and used the laminar spreader to spread and get the area ready for the allograft. So after the distraction in the previous slide, this is the allograft. Of course, you can use an autograft. This is an allograft here to distract between the calcaneus and the talus. So now they have a distance between them, and then fusion or fixation of the subtalar joint to obtain the fusion. And you can see here the relation between the calcaneus and the talus improved. So the talus now became more of an oblique rather than flat. So as we discussed, in the pathology of the malunited, you can get broadening of the calcaneus. The broadening happens mainly from the lateral wall blowout, as we discussed. And if you have massive lateral wall blowout, it's better to use the extensile lateral approach because you can reduce this better with the extensile lateral approach more than the sinus tarsi. So if you have a patient who have malunited calcaneus and the main issue that he has is the lateral wall blowout, which definitely can cause pain with the shoe wear and also can cause pain with the peroneal muscles that are here, the treatment will be lateral wall exostectomy, and this sometimes comes in the exam also. So if they give you a scenario for a patient with broad calcaneus causing irritation of the peroneal tendon and the CT or the X-ray show widened calcaneus, the treatment is, in this case, is lateral wall exostectomy, as you can see here in this drawing. Thanks for listening for this lecture. I hope this lecture and the other lecture in this channel will help you to understand orthopedic and also to help you with your exam.